Today, I have been given the honor of introducing our guest speaker, Dr. Dina El Demellawy, who will be sharing a very informative and knowledge-driven 2-hour presentation on pediatric and perinatal pathology. But before this, I'd like to give a brief introduction of the outstanding contributions that Dr. El Demellawy has made in the field of pediatric and perinatal pathology. Dr. Dina El Demellawy is a pediatric pathologist at the Children's Hospital of Eastern Ontario and an associate professor in the University of Ottawa. She completed her anatomical pathology residency training at the University of Toronto and her pediatric and perinatal pathology fellowship training at the University of Pittsburgh Medical Center. Dr. El Demellawy is appointed at the Children's Hospital of Eastern Ontario Research Institute as a clinical investigator, and her main clinical and academic interests are perinatal, pediatric, and bone pathologies. She had contributed to a few book chapters, has over 85 published articles in peer-reviewed journals, and over 80 abstracts presented and publications in national and international meetings. She has had over 20 successful local and national grants, including CHIR, PSI Growth Awards, and Translational Research Grants, amongst many others. She's also actively engaged in teaching of undergraduate and postgraduate students and trainees. Dr. El Demellawy is the current coordinator of Pathology and Laboratory Medicine Committee and the faculty on the Tom Smallman Canadian Orthopedic Association of Basic Science course. She held a few administrative and committee positions, including the Director of Immunohistochemistry at William Osler Health Center, the Director of Histology Laboratory at Health Sciences North in Sudbury, and a member of the Archives Committee in the Society of Pediatric Pathologists. Dr. Demellawy is a motivating figure for many of us in the MBBS program, and especially those of us who wish to pursue pathology as a career. She's an inspiration to many, and we are all very honored for her to speak to us this evening. So I ask where you are to welcome Dr. Dina El Demellawy.
Many thanks to you for a very kind words and very nice introduction. I really appreciate it and very delighted to be with you all today. So I'll share my screen and we'll begin. You see my screen and the arrow. So during the coming hour, we'll just speak about pediatric and perinatal pathology as a subspecialty in pathology. I aim, see if we move that here. I aim through this hour of talk to just give an overview about what this subspecialty or pathologists in such subspecialty do, also to share some examples so you understand how much we contribute in the patient care, as well as to give an idea of how to get in this subspecialty if any of you is interested to pursue a career as a pediatric and perinatal pathologist. So very quickly, what we do in perinatal and pediatric pathology, it's like what pathologists do in general. So it's really, we study pathology and we study the diagnosis of human diseases. So our work is to diagnose human diseases, but in pediatric and perinatal pathology, it really involves a certain population with a certain age group. So the perinatal component is involved with the placenta, embryo, fetus, neonates. The pediatric component is involved with diseases that occur in infants, children, and adolescents. So it might be very different than other subspecialties in pathology, where to many of you or some of you might say, why the fuss? Why are we looking at a specific population and not really going like with other pathology subspecialties to target an anatomical site? For example, when you speak about the neuropathologists, they diagnose the pathology in the brain, in the spinal cord, so it's certain anatomical locations, similar to the thoracic pathologist, similar to the gastroenterologist, right? It's like anatomic location, and then you study the diseases and the lesions that come with it. In pediatric and perinatal pathology, really, we study a population. We are really deal with everything, with every disease that occur in human from the moment they become an embryo till the moment they start their adulthood. So it's really a study of a population time. And the reason for that, because children are not little adults. They are a specific population that display a unique disease profile that require pathologists who diagnoses these lesions or tumors have a special training and special diagnostic skills. For example, for perinatal and pediatric pathologists, they deal with stillborn, which means autopsies on fetuses that can be very, very tiny. They can be 15 weeks, they can be 16 weeks, like in some cases, I'll have an autopsy case that really, the whole fetus is less than my hand in measurements and everything, and I'm looking at organ per organ, trying to identify the pathology there. Similarly, placental pathology on those patients who have high-risk pregnancies requires certain expertise. Any adult pathologist in other subspecialty cannot really interpret and needs a specific training in order to do those. Tumors that occur in children are very different than tumors in most cases that occur in adults. So with this, a pediatric and perinatal pathologists require education that encompass general and systemic aspects of surgical pathology and autopsy. We have to be skilled in the understanding and the knowledge about embryo, fetal, perinatal, and placental pathology, as well as a pediatric pathologist has to have to grasp the pediatric aspects of dermatopathology, hematopathology, cardiovascular pathology, respiratory pathology, all other subspecialties that are done in adults, but to be focused on the pediatric aspect of it. Depends on the institute. In my institute where I work, which is the Children's Hospital of Eastern Ontario, we're 4 colleagues who do the general pediatric pathology, which means the pediatric and perinatal pathology of everything except for 2 subspecialties in it, which is the neuropathology and the forensic pathology. We are very blessed to have a colleague of ours who specialized in pediatric neuropathology. So she reads all the neuropathology work in the pediatric age group as well as in the fetuses. And most of our forensic pathology work is carried by our other colleagues in the forensic center. The pediatric tumors, the perinatal autopsies, the metabolic diseases, most of the work we do requires a huge diagnostic workup, which usually involve ancillary studies, not only the microscope, not only the dissecting microscope, not only the gross examination and the light microscopy, but in many cases, we have to involve immunophenotypic studies, cytogenetics, molecular, histochemical techniques, and ultrasound and ultrastructural pathology in order to reach the correct diagnosis. In many centers, the pediatric pathologists work in pediatric hospitals, and this requires not only to be able to interpret and do the diagnostic pathology work that's required as part of the pediatric patient care consultation or the maternal fetal medicine care consultation, doing the conferences, the rounds, but also because it's usually in a setting of a separate children's hospital, many of the pediatric and perinatal pathologists are required to do laboratory management, quality assurance, data processing, teaching, and other scholarly activities. So if with that, you have an interest in this subspecialty, so there will come the next question. Okay, we're interested, how can we get licensed or we get into, we get a future career in pediatric and perinatal pathology in Canada. So I'll speak in the coming 2 slides comparing like really speaking about North America, so comparing Canada and the US. So in Canada, first we have to go into pathology because pediatric and perinatal pathology is a subspecialty. So first we have to go into pathology in order to be able to take, after we finish our pathology residency and postgraduate training that's mandated to become a pathologist, then we take the extra step to become to do the subspecialty of perinatal and pediatric pathology. In Canada, in order to enter residency program to do pathology, or in general, any other subspecialty, you need to be a Canadian citizenship. You need to hold the Canadian citizenship or be a permanent resident in order to do that. Usually, visa holders are not eligible to go further to do the residency training in Canada. However, there are few positions and some exceptions are done for non-Canadian citizens and non-Canadian permanent residents, but those must have a sponsorship support. These are usually like medical students who finish who have their medical degree, and then they require a focused residency training or focused training in certain field, and they are sponsored by their countries, and they usually coming from Gulf areas like in Bahrain, in Saudi Arabia, where they have the funds, they do the training, they get the expertise, and then go back to bring it to their countries. But in general, in Canadian residency, you need to be to become a permanent, to have a permanent resident status. Once you have that, you need to write the Medical Council of Canada Qualifying Exam Part 1, to write the National Assessment Collaboration Examination, and certainly to show some language proficiency, whether English if you are going to most of the provinces in Canada, or French if you will be, you intend to write the exam in Quebec. Once you have those, you're eligible to apply through the Canadian Resident Matching Services, which is the CPALMSI, which basically you apply your things. Besides, there's transcripts from your school, there's references letters. So there are things actually, even if you are at the first stages of the medical school, you can start together. So all can help you if you're aim at the end to do your residency in Canada and to become a pediatric and perinatal pathologist. And through the matching, there is a matching process, and through it, candidates are able to secure residency in Canada. Most provinces in Canada, they have two types of match: a match for international medical graduates and match for Canadian medical graduates, and they don't overlap. So there is secure positions for international medical graduates. And in my opinion, and by the way, I'm an international medical graduate. When I entered Canada, I came through that pathway. And I think that this is a good thing to have a secure position for international medical graduates, because in Canada, it's very different than many of the medical school system is very different than in many international countries. For example, like for myself, I didn't have, once I finished high school, I was able to enter medical school. In Canada, it's different. You go through an undergraduate program that's usually 4 or 5 years. And then after that, you can apply for med school. And in many times, Canadian graduates cannot get in, and they start to do a master or PhD, which they finish, and then they enter medical school. So they, you know, like when I think about, say in my situation, I just finished med school, I just finished high school, entered med school, and then I was going to compete with other candidates who have masters, who have PhD, who had an undergraduate degree, plus the med school degree, and I'm competing with them. In my opinion, it's actually a nice thing that the international medical graduates are not competing with the Canadian medical graduates, and they have their secure spots. One other thing to keep in mind if you will consider this route in the future is that although the CARMS have its own rules and its own application, each province have their own eligibility criteria. And there's something to look at, because if you thinking of applying for permanent residence in the future and pursuing this career, then maybe which province you want to be a landed immigrant on the choice you will make will be related to the eligibility criteria that varies somehow from one province to another. Okay, let's look at the US. So the US, if we want to do a residency in pathology, how does it work? So the US, like Canada, recognizes pathology as a specialty. So it requires residency and postgraduate training. So the first step for it, you need to apply for the Educational Commission for Foreign Medical Graduate, or ECFMG, and that's easy. That's like your transcripts, your things, because most of our universities are eligible, and through it you can apply for this. Then you have to write the United States Medical Licensing Examination, the USMLE Part 1 and 2. And then after that, you get this and you apply through electronic residency application service, which is ERAS. It gives you a token and a number, and through it, you can apply to the National Residency Matching Program, which is like the CARMS in the Canadian side, right? It's very important to note that you don't need a citizenship. That citizenship is not a requirement for ECFMG applications. So in order to have a residency in the US, you don't need a citizenship. You don't need a permanent resident. You don't need a green card. What happens once you get matched to a program, the ECFMG sponsor a visa for you. It's called the J1 visa. So it's very different than the Canadian. And I had in my career, I've done during med school when I was in Egypt, I've done my USMLE, I've done my ECFMG, I become ECFMG certified during my med school in Egypt. So when I was studying, I did it as part of my study, like I applied for it and I did it. So that's a good thing, in my opinion, to do. And it helped me when I needed to do a fellowship after my residency. I used my my ECFMG certification in order to get a fellowship in the US. For Canada, I needed to be granted first as a permanent resident in order to be able to write my exams. So I couldn't write my Canadian exams until I'm landed immigrant in Canada. So I've done it at a further stage in my career. So something to keep in mind. So I put a few, those are few links. They will be in the, if you want to review the talk afterwards. I put this new links because I've done my like my ECFMG, my USMLE, my LMCCs, all of this, I've done it more than 20 years. So I just had to review things to make sure it's updated to what's current when I give the talk. So I found that these websites are very interesting and very informative. So now we focused on how to get a pathology residence in North America, whether the States and whether in Canada. One thing to keep in mind, and it's very important when you make your choice whether to go through this pathway or that pathway, is that the Canadian residency programs are very limited. The spots are very limited for international medical graduates, and even for Canadian, very limited compared to the US. The US have many programs compared to Canada. So it's much easier, in my opinion, to get a residency in the US compared to Canada. But again, every individual have their own circumstances, and what I'm trying to say, there's more opportunities in the US as regards residency, and actually as regards fellowship training as well compared to Canada, because there are more spots available. Okay, so when we speak about pediatric and perinatal pathology in Canada, so 2020, the Royal College of Physicians and Surgeons of Canada recognized pediatric pathology as a subspecialty. So before that, we just write the Canadian exam that any pathologist in Canada can write, and then you can practice pediatric pathology. Of course, not many institutes will hire someone without a fellowship or formal training, because it's really a subspecialty that requires skills that you don't get it through your regular residency training. But the college didn't recognize or didn't put it as an area of focused competency until 2020. So now it's required to have at least 1 year of fellowship or focused training in order to practice pediatric pathology. So the Royal College recognized 8 different programs that can offer this training. Children's Hospital of Eastern Ontario is one of the recognized sites where I work. And this goes from the east and west side, like almost in every province, there is 1 or 2 programs that are approved by the college. However, as regards the fellowship spots available, it's very limited in Canada. And basically, it's usually University of Toronto and University of Alberta are the 2 programs that have a constant position that's offered every year, but it's really like the number of fellowships is less than the number of my fingers in one hand. So when we consider, even as a Canadian graduate, or even as IMG who finished my residency in Canada, when it came that I want to do this subspecialty, I know that the spots were very limited in Canada. But the good thing is that the American fellowship programs, which are huge in number, there's a lot of spots available in the US. I'm as Canadian, as an individual who finished my residency in Canada is eligible to do and can apply in. One thing to keep in mind that the American Board of Pathology Certification do not recognize the fellowships in Canada in pediatric pathology. So if I finished a pediatric pathology fellowship in Canada, it's not recognized by the American Board Pathology Certification. So let's go on the history very briefly on the American Board of Pathology certification. So when did they recognize that pediatric pathology is a subspecialty? So we said that the college in Canada just very recently recognized it in 2020. Actually, in the state, they recognized it in 1983. They started to say not anybody who's board certified out of residency can do the subspecialty. You need a formal training in this subspecialty in order to be able to do this complex diagnosis. The first exam for pediatric pathology started in 1990, and it was in Atlanta, Georgia. In 1991, so a year after, the American Board of Pathology allowed Canadian pathologists, so pathologists who wrote the Royal College exam, the Royal College of Physicians and Surgeons exams in pathology in Canada, to write these exams. Because it was in 1991 a transition, they also recognized pediatric pathologists with expertise and experience in pediatric pathology, and they allowed them at that time to write the exam. So currently, how does it work? So pathologists receiving their pediatric and perinatal pathology subspecialty training in Canada is not eligible to write the pediatric pathology examination certification. However, Canadian pathologists certified by the Royal College of Physicians and Surgeons of Canada can do fellowships, can do their training in pediatric and perinatal pathology in the States without writing any further exam. You have the Royal College you successfully passed the Royal College exam in Canada, you can apply for fellowships in the States and get your training there. And through that, you can write the pediatric pathology exam of the American Pathology Board. So I hope with that we get some idea about the two pathways we can go in. As I mentioned before, I finished my residency in Egypt. I finished my medical school in Egypt, did my residency in Canada, did my fellowship in Pittsburgh in the States. So I went through the two routes. I think honestly you will get the best education and the best training in any of these routes. It's a matter of opportunity. Okay, I guess if any question, I'm happy to take questions, and then we'll go through any through cases to show what this what we do really in terms of patient management. And any question? Okay. If not, I'll go through the examples, and I hope it starts. We start to engage as we go through the cases. So I might ask some of you to unmute as we go through the cases. So the first case I'll give through the perinatal component. So it's something to deal with diseases that's occur during pregnancy in the perinatal period. So this is a mom who's 31-year-old. She's gravid of 5, so she had 5 pregnancies, 4 abortions. She doesn't, like all of them are abortions, none of them reached 20 weeks, except the current pregnancy, where she is at 22 weeks. So history, many abortions. In this pregnancy, she presents with anhydramnus. So there isn't really, there's oligohydramnus and now reached the degree of anhydramnus. They do the ultrasound and they find that this baby is very small for the growth parameters by ultrasound compared to what's expected at 22 weeks. That's what we call intrauterine growth retardation. There is a lack of almost 1 month measurement in the size of this baby compared to what's expected at 22 weeks. By ultrasound, there wasn't any congenital anomalies. And this is a major point because with mom, with multiple miscarriages, one of the things can be a syndromic condition or a congenital anomalous, something that leads to these recurrent miscarriages. As a result, when this baby or this mom was brought to attention, definitely to the obstetrician, and was managed in the maternal fetal medicine, with the maternal fetal medicine, but as well with the genetic team. And they take a chorionic villus sampling in order to do some testing to rule out any genetic abnormality underlying to explain this recurrent miscarriages and to help the mom to have a baby finally. So because of the anhydramnus and the significant IGR, there was induction and termination of pregnancy. And definitely a baby at 22 weeks, the lung is very immature and incapable, even if this baby was healthy, to be viable. So the Apgars were all zeros, and it's below the age of viability. So this baby, there was a request to do a fetal autopsy on this baby. And I'll ask Jessica if you can work with me this case. Can you unmute and we go through this case? Anyone? Any volunteers? Any volunteers? Okay, so I'll continue. I wish to have an engaged session. So when we look at this fetus, the first thing we can see is that the head, like, I can tell you, since this is part of my work, this baby looks very small compared to what would be expected at that age of 22 weeks. when we look at the head is relatively big in proportion compared to the rest of the body. One of the things we do with perinatal pathology is we measure the foot length, we measure the hand length, we weigh the baby, we measure crown to heel. So it's really the length of the baby, crown to rump, right? Head circumference, and we have parameters that we compare. What do we expect at 22 weeks? And this is what you see in the parentheses over here. And what we see here, that this baby is much smaller as regards the growth parameters and weight compared to 22 weeks. In fact, the measurements more fits 16 to 18 weeks. So there is a lag of 4 weeks or more, as noted by ultrasound, as regards the measurements. So we know that there is intrauterine growth retardation. So this baby is small. The genetic workout showed with the oligonucleotide array analysis, there was no abnormality. So again, we cannot help the mom based on the genetic results. All we know, there's something pathological that making this baby not grow enough, and the mom have recurrent abortion. Part of the perinatal workup is always to examine the placenta. When we looked at this placenta of this baby, what we can see is that this is the color of a normal placenta. It's supposed to be like a sponge and like maroon color, like maroon reddish color. But what we see in these cut sections, like the placenta came and we really bread loaf it. That's in simple terms, that's what we did. And we're looking at the slices of it. And what we see this creamy color or tan color or caramel color that's going in between and radiating through the placenta. And honestly, the only area of normal is here. All of this is abnormal. So there is some sort of something infiltrating in this placenta. And the easiest way in perinatal to think about the placenta, I think about it, it's the lungs of the baby. The baby doesn't breathe through their lungs when they are in uterus. They breathe through the placenta. So you can imagine this sponge. The spaces in is your alveoli, and it's all blocked. So this baby is not able to get the demands he needs from oxygen or even from nutrients because of something material blocking and infiltrating in this placenta. So in this left-hand side, this is how a normal placenta will look like under the microscope. You will have villi, these things where the blood vessels here are the baby blood vessels, and the spaces, those spaces, white spaces in between is mom blood. So the placenta acts like an exchange site where mom's blood over these spaces, carrying oxygen, carrying nutrients, get diffused to baby blood vessel over here and take the oxygen, take the nutrients, and then put the carbon dioxide, all the waste products over here to return it to mom site in the intervillous spaces. When we look at this patient's placenta, what is happening? We don't have the intervillous spaces. Instead, we have this material, this very pink material, blocking all the intervillous spaces. This pink material is fibrin. So we have extensive fibrin deposition in this placenta that make it dysfunctional and cannot do its exchange function in order to provide nutrients and oxygen to this baby. So there is no doubt why this baby cannot grow and why eventually was going to die. And this process was so extensive that it goes throughout the placenta from one section to another, like it's really very small areas where you start to find there are very tiny spots to find exchange there for the baby. Again, this is normal placenta. This is the placenta we have, most of it with this bright pink material representing fibrin deposition. But as well, like most of the intervillous spaces in a normal condition should have these red blood cells. You see these red dots are the red blood cells. They usually represent maternal blood over here to do the exchange. When we looked closer, we can find cells bigger over here that represent histiocytes. So even the infiltrate in the maternal intervillous spaces that's supposed to be red blood cells of mom, it represents histiocytes. Again, this is a closer look showing the fibrin material deposition and bigger cells, not red blood cells, cells with a nucleus, which on staining confirmed they are histiocytes. So this is a picture using immunohistochemistry. Immunohistochemistry is a technique that's used to know the cells. So we look at things by morphology, and then we pick certain stains that will target the lineage on each cell in order to be sure what type of it. So here we are using the stain, the immunohistochemical stain with CD68. 68 is a protein that's specific to histiocytes. So when the cells have this protein, they will stain brown. So all of these brown cells are histiocytes. So the intervillous space is populated by histiocytes and fibrin. We have a disease in placenta called massive periphyllous fibrin deposition and chronic histiocytic intervillositis. This is a very rare disease. It's associated with severe intrauterine growth retardation. Moms usually suffer of fetal loss and stillbirth, very recurrent, high recurrence rates. Sometimes it reaches 40%. There is no standard management, but there are many case reports that show a value for intravenous immunoglobulin, heparin, and aspirin use that make this baby pass the stage of viability and even reach the stage of third trimester viable, because these drugs counteract the fibrin deposition that induce this blockage of placental function and enable the placenta to carry its function through, I won't say till term, but at least through a good stage that you can induce labor at some point, and this baby become viable, and mom can have a viable baby. One thing to keep in mind that, especially we are at the COVID period, that SARS-CoV-2 virus, in many of the cases, particularly those moms who are severely ill with it and they are pregnant close to the time of their delivery. So when they deliver, they are in active stage of COVID infection. The placenta may show similar histology. Similar, like the chronic histiocytic intervillositis, the massive perivillous fibrin deposition, you can see it. You can't tell the difference. Usually with COVID as well, you see the trophoblasts, so the lining of the villi have degeneration and have necrosis, which usually not seen with the classic massive perivillous deposition and chronic histiocytic intervillositis. Malaria infection is another histological picture in the placenta that may overlap with this disease. So can show similar thing, but it's due to infection with malaria. So those are two things you keep in mind before you make the diagnosis of massive perivillous fibrin deposition and chronic histiocytic intervillositis. In this case, it wasn't a problem that much because number one, the history of recurrent abortions is something you won't see with SARS-CoV, and the mom started her history of recurrent abortions in 2019 before even we started to have the COVID in Canada. This mom, 5 months later, she tries again to have a baby, and unfortunately she ended with an abortion at 10 weeks. And then the maternal fetal medicine clinician, he asked me to look at this baby to see if there is, at this products of conception, it's very small, right? The measurements is like 9 weeks. And he asked to see if there is similar pathology or not. And on looking to it, we can see the chorionic villi over here. So these were the things that carry the baby vessels, but we can see in between there is a lot of fibrin over here. This is mom's side, decidua. This is the intervillar space for the exchange, but we can see the start of a lot of fibrin that shouldn't be there. And again, this is a closer look. So that's the villi of the placenta, where these blood vessels are the fetal vessels to do the exchange. And this is the intervillar spaces, and it have this pink material of fibrin blocking the maternal blood. So instead of having maternal blood to do exchange, it's blocked by fibrin and lots of these histiocytes. So when we did the immunohistochemistry using the CD68 that enabled to identify these cells as histiocytes, they were populating the spaces. So actually, this disease started very early in pregnancies. And like this, this suggests that her previous recurrent abortion, the 4 times she had abortions before, are due to the same disease, which is massive perivillous fibrin deposition and chronic histiocytic intervillocytis. And that this disease even started very early in baby. This fetus was 10 weeks and this disease is starting. And currently this mom is pregnant, and so far, like the obstetrician, she's watched under the maternal fetal medicine, and she received the aspirin, the heparin with the follow-up, and currently she's reaching mid-second trimester without any complications. So we might hear good news that this mom finally have a living baby, because just examining the placental pathology and identifying the pathology. Tons of tests have been done through genetics, but wouldn't have helped. It's really the sections that's taken from the placenta helped to help this mom to have a living baby. Okay, any question? I guess
I do. I have a question.
Yes, please. I wasn't sure someone is listening or not.
No. What happened? I was driving earlier in the gap, and I didn't want to interrupt. I was waiting for the students. So, first of all, Dr. Demellawy, this is really interesting. So, tell us, how long was your residency program in Canada? I'm sorry to be backtracking. And the second, how long was your pediatric pathology fellowship?
Yeah. So basically, I'll tell you the story in detail. So when I was in Egypt in med school, I always aimed to do my residency in North America. Like that was one of my targets. So during med school, I wrote my USMLE and I became ECFMG certified. So I could apply for residency at the time. But I decided to wait until I finish. After finishing the med school, I actually went to pathology residency in Egypt. It's only 3 years. I did my residency in Egypt, and during it, I applied to be a permanent resident in Canada. And when I got my permanent residency in Canada, I came as landed immigrant and started to do my qualifying exams and things through the Canadian pathway. I passed them and applied, and I went through a residency program in Canada in University of Toronto. At the time, they recognized they had a program for international medical graduate that they make you write an exam to assess your level of knowledge on the subspecialty. So remember, I've done 3 years in Egypt. I finished actually my full residency in Egypt. And they assessed my level and they put me as a PGY4 in Canada.
Right, so you basically jumped the line.
I jumped the line. Finished my residency in 2 years, wrote my exams in the Royal College, no problem, started to practice as a pathologist, a general pathologist in Toronto. Stayed for a few years, and then I felt like I really don't want to do only the bread and butter. I want to do a subspecialty, and I got interested too much on the placental pathology. At that time, the fellowships in Canada are very limited. So I used my USMLE that have been like almost 14 years old, but they were still valid because I finished all the ECFMG certificate and everything and applied for the States and got into residency in Pittsburgh. And in 1 year fellowship, I wrote after it the Pediatric American Board subspecialty. It's very convoluted what I did, but it's the way I thought about it, and very frankly, I have my husband. He's as well, like we were in the same year of med school, and he's a surgeon. He's a pediatric surgeon in the same institute I work. And one of the reasons we did our residency in Egypt first, and we went through the Canadian route, because the States have many spots, but the problem is that you are in J1 visa. So after you finish your residency, if you cannot secure a job, right, you will go back home for 2 years. You have to leave the country for 2 years. So we decided to go through the Canadian pathway because you come as permanent resident. So you are not worried what to do. Once all your fight is to be in the system, to be in the residency, right? But you're not worried after that what will happen. So that was our thought. That's why we didn't go on the States. We wanted to go through the Canadian route.
Right. Thank you very much.
Okay. Okay.
Hi, doctor.
Yes.
I wanted to know, at what years during your med school did you write the USMLE 1 and 2 and the ECFMG?
Yeah. So in the third year, like the Egyptian system, like, you know, from high school, then you enter med school. And then the way it works, the first 3 years are basic sciences, like the histology, the anatomy, the pharmacology, and these are really very parallel to step 1 in USMLE. So at the end of my third year, I wrote the USMLE part 1. And then I started my clinical years in the 4th, 5th, 6th years. And by the end of the 6th year, I wrote my step 2. Like they are gapped, but what I did at the highest memory and at the highest of my study to every part, I wrote it in. And that's how I can score very well, because as an international medical graduate, you need not to get an average score in order to secure a residency of your choice in a nice program, right? You need to score a high score. So it was actually easier at the time when I wrote it at med school, because it was what I'm studying. It was an exam on what I'm already fresh and studied. It was harder when I went after residency 3 years, and then I started to do, and especially my residency in pathology. So 3 years, not really doing exams or seeing patients or something like this. And then I immigrated. And then after immigration, I wrote my exam around 6 months or 9 months after in Canada. So almost like 3+ years, not showing patients and starting to do to write exams about clinical work that I don't do. I became very much microscope person, right? So it was harder. I passed it, which was good, but it was harder. What I'm trying to say, do the exams, particularly the USMLE, because you have the ability to do it from your home, from without any immigration, without anything. You can do it right now. Pick the time to do step 1, which is the basic science, at the time that parallel your study in your university right now, in your med school years. And once you start your clinical, once you finish, most important, internal medicine and psychiatry. Those are the huge thing that fills step 2 is really internal medicine and psychiatry. Once you finish your rotations and your education on those, write your step 2. The ECFMG is just, it just comes by, like it's just the paperwork and the thing after. But the USMLE part 1 and 2 you can do it, but do it at the time you finish the basic science part. You write USMLE part 1, the clinical part, you write the USMLE part 2. Does this answer your question?
Yes, it does. Thank you.
It's honestly like I went through this more than 20 years ago. At the time, it was like, I'll say there was some challenge, but when you're young, you just don't waste time. You focus, you know what you want, you work hard for your target, you reach it. And in my opinion, it's worth all the effort. Okay. Any other question? Okay, so I have another clinical case. I don't know whether we have time or.
Yes, Dr. El Demellawy, you have more than enough time.
Okay, so if anyone wants, Gabrielle, do you want to, we walk through this case together, or what do you think?
Yeah, sure.
Okay, so this is a patient who is 9-year-old. So I showed you one case on the perinatal, the other example on the pediatric, just to show like we still have to do the regular pathology on bone or respiratory or beside the perinatal, which is very focused area. So this case is a 9-year-old boy who presents with 2 months of knee pain. There is no history of trauma. So it's not like somebody hit him or he falls or something, and there isn't any weight loss or fever. And then I'll ask you, this is his X-ray. Do you think anything abnormal on this X-ray, on this side?
On this side, to me, it looks normal.
So let's go step by step. So this is the cortex. The cortex usually is more radiodense, or let's say it like more white compared to the medullary cavity of the bone, because this contains bone marrow, this contains solid bone. So bone in X-rays is white, right? So yeah, so I can see the cortex smooth and nice, right? I can see that this is a kiddo because I have a growth plate. You see how the head of the femur over here, there is a lighter line here, because the growth plate is usually formed of cartilage, not bone, so it will be less white. Let's go to the other side, cortex, 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 and then area, I cannot really with a pencil trace it. Like you can see this area here. It doesn't, it looks like the cortex, that thickness, where did it go? I'm really not sure it ends here or here or here. And there is some white areas over here. This is actually a destructive lesion in the metaphysis. So metaphysis is the part of the bone. This is the head of the femur. This is where it starts to narrow to become the shaft of the femur. This area, we call it metaphysis or metadiaphysis because it's starting to be on the shaft a little bit. There is a destructive lesion. And why this lesion is destructive? Because the cortex here, that's smooth and nice, suddenly blurred, and I cannot find where it ends and where it begins. In my hostel here, they have this 3Ds on imaging, which I like because I'm not a radiologist, so it's very easy for me. I look at this picture and I can see normal bone, something very bad here, something shattered the bone. So I know there is a pathology. And that's one of the things I do whenever I look at any bone case. I always look at the imaging, at least the X-ray or the 3D. I don't go to the CT scan. I just read the report because I don't know how to interpret it. But I just want by my eye to make sure that there is a big pathology here and whether it destroyed the bone or not. And the reason for that, because in kids, it's very easy. If you have a destructive lesion in the bone, in a child, aggressive destructive lesion means two things. Means either Ewing sarcoma or osteosarcoma. Very rarely you'll have a bone metastasis in a kiddo who have a neuroblastoma or whatever. And usually in kids, like these tumors show before the metastasis in the bone. So really, just with this X-ray, I know I'm dealing, because that really shattered the bone, I know I'm either Ewing sarcoma or osteosarcoma. And why I do that? Because if they give me a biopsy that doesn't show a tumor with something with this imaging, I know that their biopsy is not good. I'll tell them to repeat, and it's not representative. What do I mean? So here is the X-ray again, and we can see from it, we have a destructive lesion of the bone. It's affecting the metadiaphysis. This region, we call it metadiaphysis, and it's a big lesion. It was 4.8 centimeter maximum dimension. Automatically, they see this in X-ray, then they need the pathologist to tell them Ewing sarcoma or osteosarcoma or what's going on, because the treatment regimen differ. Even both Ewing sarcoma and osteosarcoma are both malignant tumors. The treatment, the chemotherapy given is very different. So they have to know exactly what type. So we have in my institute here in CHIR, we have interventional radiologists. So they stick this big needle and they take just tiny pieces of the tumor. So this 4 centimeter, 4.8 by 2 point something, that's what I get from it. Just 2 small things that's 0.1 in thickness and in length 1 centimeter, 2 pieces that address the diagnosis for a kid that may end by he or will receive the chemotherapy for sure, but even may end with some major surgery that might in some cases lead to amputation or, you know, like a major surgery. So you have to be 100% sure. So so you see how small the cores are. This is what I get on a slide, just 2 little pieces like this to make the diagnosis. So if these pieces comes like something not malignant with this picture on X-ray, I'll say repeat. It's not enough. It's not representative, because I know from the imaging that there is something very nasty, very malignant going in this bone. So that correlation is one thing that's very important to do in pathology. Okay, so then we get the core. So this is how you see a normal bone. A normal bone is a pink matrix, like something just pink homogeneous material like this. And the cells inside it is called osteocytes, are those ones with the purple nuclei, and they're usually in a space. And this is how a bone marrow looks like. It's just this dots of those precursor for erythrocyte, for red blood cells in the blood, white blood cells. So we call them erythroid series and myeloid series, like here. What I get from the core is like this picture. So I'll ask Gabrielle again. Do you think that these cells look similar to this in any way?
No, they don't. You can barely see like the red blood cells.
They look different. Do you think that if I tell you that this is one cell, do you think it's much bigger than those? It's the same color, same magnification.
Yes, but it's large.
Very, very bad with huge nucleus. They look ugly. Every cell look different than the other. This is a closer look. You can see no cell look similar to the other. And that's the criteria for malignancy, that each cell looks very different. We call it pleomorphism. Each cell have its own look different than the other cell. And the reason for that, because what happened with malignancy in a normal tissue, even in a tumor that's benign, you're still under the control of impulses for this cell growth. So it's one control and all the cells going at the same direction. What happens with malignancy, every cell at different control, at the control of its own. Or in other words, they are out of control. They just grow and never die. So each cell look different. Each cell, the amount of chromatin is different. The size of it is different. The cytoplasmic staining is different. That's what we look pleomorphism, and that's one of the criteria we look under the microscope to assess malignancy. And when you look at them, this is a cell that's almost all of it formed of a nucleus. If I tell you a normal cell, usually the nucleus, if it's 1:4 ratio between nuclear to cytoplasmic ratio. So the nucleus is supposed to be a dot in a large pool of pink cytoplasm. This is a cell that's almost all nucleus. That's another criteria of malignancy. And then when we look at it under the microscope, these are skeletal muscle fibers. So you see the nucleus, how small compared to the amount of cytoplasm. And I can see the malignant cell. Look at this bizarre, ugly cell is infiltrating into the muscle. And that's what's happening here. This tumor is here, ate the cortex, went out in the skeletal muscle that's attached to the bone and infiltrated. And no benign tumor can do that, only malignant tumor. And in kids, 2 malignant tumors occur in bone because metastasis is very rare. Like if it's an adult and you look at imaging like this, the first thing you say, metastasis. In pediatric, it's different approach because, as we said, pediatric patients have a different disease profile. So usually the tumors in them is primary bone tumors, not metastatic like in adults. And with this, we have 2 primaries that occurs in kids. Ewing sarcoma is just blue round cell tumors. All the cells are done with nucleus. There is no cytoplasm. And osteosarcoma is cells with big pink cytoplasm, much bigger cells, looks like this. And they have the ability to form osteoid, which is like the matrix we have seen in the normal bone. Does it get easy at this stage? No. For pathologists, still you have to know it's osteosarcoma, good, but what type of osteosarcoma? So osteosarcoma have several types. Conventional type, like what's in this diagram is seen. So it involves the medullary cavity as well as the cortex, and usually it have some sort of stretch to the periosteum like here. And then there are variants which are less common, and it's important to recognize them because some of them you don't give chemotherapy. So for example, paraosteal osteosarcoma like this one, it doesn't involve the medullary cavity, it's usually on the surface, and all the treatment for it is surgery. You cannot give chemotherapy in it. So you have to be able, as a pathologist and as the radiologist, to know what type of osteosarcoma it is, even for the pathologist on this small biopsy. And when I looked at this one, so here it is. Does it look like this, or this, or this, or this, or this? What do you think, Gabrielle?
It looks more like E. Yeah, it looks like E.
It looks like which one?
E.
It looks like E here?
Yeah, but
That's a good thought. What about A?
it also looks like that one as well.
And that's an excellent thought. The difference between E and A is that E is a cyst. It's a type called telangiectatic osteosarcoma, and the radiologist will say it's full of fluid. The type of A is the conventional osteosarcoma, looks the same, but it's all solid. And in this case, the radiologist told in his report it's all solid. So it fits with the conventional osteosarcoma. But it's excellent. I'm so happy you said that, because really it can be that or that without the information whether it's solid or not.
Doctor, for E, could they drain it, seeing that you said it's a cyst?
Yeah, the telangiectatic osteosarcoma is all cyst. Like what happens with this osteosarcoma, start to have hemorrhage in it. So when the radiologists look at it, it's like blood lakes, but they still have the malignant cells who are eating and expanding. While the conventional osteosarcoma, which like this case, all of it is just solid malignant cells. There isn't the areas of hemorrhage. And most of people think that telangiectatic osteosarcoma is actually conventional osteosarcoma, but there is hemorrhagic change came on, something we call it aneurysmal bone cyst change. Like it just degenerated into hemorrhage, but still the malignant cells are there. And still it have to have the same treatment as conventional osteosarcoma, because the malignant cells are still there, will keep on going, eating and destructing the rest of the bone, and can lead to metastasis and kill the patient. So with what did the pathologist did? What did we do? We got the first thing, the few small pieces that the interventional radiologists have given us, and we did the diagnosis. Then our oncologists become involved, and we tell them osteosarcoma. They have a regimen of a combination of chemotherapy that they give. They give generic, like they have, okay, for osteosarcomas, we give this protocol that includes, say, 4 or 5 chemotherapies, right? They start that, they follow the patient during the cycles of chemotherapy with imaging, and they start to see if the tumor shrink, if the tumor respond, right? And when they think they reached a good shrinkage, and remember, it's chemotherapy, it's toxic. They cannot keep on giving it forever, and they cannot giving it it's only at certain dose, otherwise because chemotherapy kills normal tissue too, right? So it's something you want to kill the tumor, but doesn't mean you kill the patient with the tumor, right? So at some point they start, the orthopedic surgeons come, and then what they do, they resect the remainder tumor. They start to go and resect, and this is the stage where it depends. Where they try to save the limb and resect the tumor, but at some cases, unfortunately, there can be an amputation, and the kid may need prosthesis after in order to walk or to do their own activities back. So it's a very nasty disease. One thing that the surgeons have to do is that when they take the resection, they need to have normal tissue, some normal tissue around. They cannot cut exactly at the area of tumor, otherwise they didn't take it all. They want to take it with the cuff of normal tissue to guarantee that all the tumor tissue have went out. So the surgeon do that, and then the pathologists get involved again for 2 things. Number one, we have to make sure that all the margins, like the areas, so say the tumor is here, he take for me a normal rim of tissue. I have to make sure that what he thinks is normal under the microscope doesn't have a tumor. This is what we call margin, because if he cut through the tumor, then he didn't do a good job. It means that there are still malignant cells inside the patient. So the patient still have the malignancy, it will grow and kill him. So when the tumor, when I get the resection like this, first thing I do, I put a paint, we call it ink, and then I start to take my sections. So why I put the ink? Because the ink will cover the surface of the specimen, meaning that any tumor cell I see at the ink under the microscope means that is still that this tumor cell continuation is still in patient. So what I do after that, I start we have a saw machine, and I cut the bone into slices. And what we see here, this is the normal cortex we have been seeing, and then the cortex is gone with the malignant tumor. You can see over here, the malignant tumor over here. This is the cortex. This is the color of the bone marrow, where the red arrow is there. And this is really doesn't look anything like the bone marrow. When I see yellow areas like this after chemotherapy, I know it could represent a dead tumor, like necrotic tumor. Tumor responded to the chemotherapy and died. That's a good sign. And that's another thing that the pediatric pathologists have to say, because it gives a message to the oncologist to say their chemotherapy working or not. Because remember, the problem in pediatric tumor is not only in the bone. Different than an adult, pediatric tumor at the moment of start, they are not local, meaning this tumor is not only in the lymph of this patient. At the time the patient presents, it's actually circulating in his blood. It's just taking time to go to his lung, to go to the boy's brain, to go to different sites, liver. So what chemotherapy is doing is trying to kill these tumor cells. That's not in the specimen I see, but it's trying to kill them in the blood of the patient before they do metastatic implants and grow. And my assessment for how much the tumor responded and died in this specimen says to the oncologist whether their chemotherapy is working or not, whether it's able to kill this tumor or not. If I don't see a good response in the chemotherapy, then the oncologists have to change their drugs. And they cannot do that from the start because they change their drugs to things that are more toxic, things that can produce more injury to the patient, and not all patients can really endure it. So again, this is a close look. We can see the dead tumor, but again, I wasn't sure about this, and especially this area. You see the cortex is here, and you have this infiltrated tumor, and it doesn't look yellow. Yellow means dead. This area looks very viable. So what we do, this is again a close look on the area of the viable tumor compared to the dead tumor. This is the necrotic dead tumor. This is the living one. And usually we put the specimens in formalin, so it changed the color, make it easier. This is the dead tumor. This is the living area. So what I do with the saw, I take a full slice, like I take a full slice of the bone, and I cut it all into smaller pieces that we call it sections. And then I examine it one by one under the microscope. We stain it, and then we examine it. And I look at every piece to assess the surface here for the margin. Does it have tumor here, here? Any area in the margin means that the tumor is still in the leg of the patient. And the other thing I'm aiming to is to look at every square on this under the microscope of tissue and see how much of the tumor died. Anything that died less than 90% of the tumor, like if I see from the whole tumor more than 10% living, didn't die, means that this chemotherapy is not working. And the oncologists have to change their treatment because their treatment is not sufficient to kill this tumor cells in the patient blood, and the patient will die if they don't change their chemotherapy. If I see in each square less than 10% living, then this chemotherapy, they continue on, this patient have a good chance to live because the chemotherapy is working. Of course, the best is to find all the tumor dead. So what do I mean? So this is how on histology, the sections look. So this is the bone that's remaining, and the bone doesn't go away. It will still be this pink material present. But in between, I see everything is dead. I don't see purple nuclei. So this is an area that's responded very well, all the tumor dead. Again, just as a reminder, this is the normal bone. It will look like this after chemotherapy. The pink will remain. The most important, I'm not seeing purple ugly cells. So this is an area that responded. This is an area where we can see the tumor still present. This is the original biopsy. Look at this area. You have these tumor cells still viable. So I have in every square to see how much viable, and I have to have it less than 10% to say it's good chemotherapy response. If more than 10%, I'll say bad chemotherapy response. I'll put the percent, and the oncologist will change their treatment regimen. They will go to more aggressive chemotherapy. That we don't know the patient how we respond to it. Again, look at here. So those are not tumor cells. This is actually iron deposition, so some hemorrhage, but this is a tumor cell. This is a tumor cell. So these are very bad signs to see them after chemotherapy. Again, tumor cells, very bad signs to see after chemotherapy. These are inflammatory cells, the small ones. See how the malignant cells are very big compared to the inflammatory smaller ones. So this patient had this resection, and good enough, like the amount of viable tumor was less than 90%. Actually, I counted it. It accounted for 99% of the tumor died. So only this foci I showed you like account for 1%. So the chemotherapy worked, The margins, the things I put the ink on, were not involved. So, and I actually measure the distance between the area of viable tumor to the margin. I give it to the clinician because the more this area is, the better the prognosis of the patient. And this case was actually in 2017, and I looked yesterday on this patient, and this patient is living with no metastasis, with anything. So the chemotherapy worked. The way we work this, we usually put the data in a synoptic reporting. So it's everything very detailed. We give it so the oncologist can understand what's the stage, the chemotherapy response, the margins, the distance, everything with too much details. But the good news, like when we assess these parameters in details, we really help our oncologist and we help our patients. And although osteosarcoma is very bad disease, many patients can be cured for it. And I have a third case, but I think it's okay. It's enough, or will you be interested? And if there is any questions. Any questions for me? Okay. So I'm. Any questions? Okay. So thank you so much for having me. And if any question, anything.
I don't have a question. I just wanted to say that these cases are very interesting.
I'm very thankful to you. And in this presentation at the beginning, I left my email. If any question, whether on how to get a career in pediatric pathology, on the pathways to take, or on any interesting case, I'm happy to respond. Please don't hesitate to contact me if you have any question.
Good evening, Dr. El Demellawy. Thank you so much for your time, taking the time to be with us this evening. We truly enjoyed your presentation. We'd just like to share a little bit of feedback we received from our session. If Ranji, you could just share your screen, please.
Okay. You got it? It's good.
Yes, as you can see here, this is some feedback from some of the participants and students. They found that your talk was interesting, it was amazing, it was intriguing, inspiring, extraordinary, fascinating. And someone even said that they found their dream specialty. So thank you so much. We really appreciate it.
Thank you so much. I'm very thankful to you and very, very delighted to be with you. And as I mentioned, please have my email. If any contact, if any question, I'm happy to respond. Thank you so much for having me.
Thank you so much. At this point, we will deliver the vote of thanks, and I do hope that everyone had a wonderful learning experience. We would like to thank everyone for attending our session, and Alfred North Whitehead once said, "No one who achieves success does so without the help of others. The wise and confident acknowledge this help with gratitude." Firstly, I'd like to thank our featured speaker, Dr. El Demellawy, who, despite a busy schedule, graced us this evening with an amazing and enlightening presentation, where we were all extremely grateful to learn about pediatric and perinatal pathology. While we are most happy that you were able to give us an insight in the behind the scenes of a pediatric and perinatal pathologist, we are hopeful that your audience was able to take pertinent notes and was reminded, if not educated, on the importance of the topic that you have presented. We would also like to extend our gratitude to Dr. Alfredo Walker and Dr. Catherine Morris, our inaugural executive directors, for joining us with their presence this evening. We appreciate your endless support and thank you for playing a key role in supporting us throughout your journey just far. We thank you all for your valuable time, effort, and consideration in the investment in nurture and properly establish the future of pathology. It's not only an act of success, but one of greatness, showing us the path that you have all walked. I would also like to especially recognize Justice Lachu, Dr. Karen Bishop, and Dr. Gary Collins. We wish to thank all our guests from the medical and legal profession, locally, regionally, and internationally. Last but not least, ladies and gentlemen, I would like to thank you all for accompanying us tonight and making our event a success, and we look forward to your continued support. To all of our UE staff and students across the 3 campuses at the University of Ottawa and Eastern Ontario Regional Laboratory Association, and especially to our specially invited guests, thank you, thank you, thank you. Our next CPALMSI session will feature Dr. Nadia Sands, who will deliver a 45-minute talk on medical microbiology in January. Ladies and gentlemen, this marks the end of our session this evening. Thank you all for joining us. So this is our 10th installment of the CPALMSI, and we hope to see you at our future events. Good evening, all.
Hi, just before we leave, I just want to recognize that Dr. El Demellawy is repping our new pathology club pin, which she received from Dr. Walker. So we really want to thank you for showing us this support, and we really, really appreciate it, especially from the Caribbean cohort. So thank you very much.
Thank you so much, and it's really a pleasure for me. Thank you so much.
Thank you very much, Dr. El Demellawy. Thank you for accepting the invitation, and thank you for repping the pin. If you could just show it to the camera, hopefully all of our members will soon be wearing one. Thanks again.
Thank you so much. Pleasure.
So alive, make it last for